Hey there, students. It's Instructor Hannah here, and we're going to talk about subcutaneous injections. So these are usually known by sub-Q or SQ for short. And these injections are given into the fatty layer underneath the skin. And it's used for smaller doses of non-irritating drugs. Okay, so the volume in your syringe must be smaller than 2 mLs. Okay, so you have anything greater than 2 mLs, it shouldn't be given into one site and into the same subcutaneous layer. Medication that's injected into the fatty tissue is absorbed much more slowly than when we administer into muscular tissue. Okay, so this is really important to know the differences, right, of why are we giving something in the subcutaneous layer and why are we giving it in the intramuscular layer. So absorption is much more slow in fatty tissue, okay? And that's because there's very little blood flow to fatty tissue, right? And muscle tissue gets a lot of blood flow. So it's absorbed more quickly in the muscle. Okay, so just a little overview of our sub-Q injections. Most commonly given are insulin, heparin, allergy shots, vaccines, epinephrine, and some infertility drugs. So the route is the fatty or adipose tissue underneath the skin layers. We're going to typically use a 1 ml to 3 ml syringe, or we're going to use a special insulin syringe that, recall, is measured in units. And the needle gauge most commonly is 25, but it could be 23 to 25, okay, depending on the size of the patient. Insulin syringes are much smaller. Typically, they are 29 to 31 gauge. So remember that those big numbers there, 31 is really, really small, right? And the 23 gauge is bigger. Standard length for a sub-Q injection is 5/8 of an inch long, the needle. But insulin syringes are shorter than that. They're 1/2 an inch. And for newborns, we're going to use smaller needles as well. Okay, so the most important thing is that the needle is the right length, okay, that it gets through the dermal layers into the sub-Q tissue and doesn't go through the fatty tissue to the muscle. All right, so it really depends on the size of your patient and the site location and how much adipose tissue there is there, and how much adipose tissue your patient has. Okay. So typically we're going to inject at a 45-degree angle to ensure that we get through the dermal layers into the subcutaneous tissue where the fat is, and we're not hitting the muscle tissue. Okay, so for a 5/8 inch needle, we're pretty much always going to go 45-degree angle to the skin surface. Okay, if we're using a small needle, the 1/2 inch, which would be for insulin or heparin, we're just going to go straight in at 90 degrees. That's usually given in the abdomen and the belly fat. So even the most skinny people, you can usually find a little bit of that if you scrunch it up. Okay, so typically we're just giving 1/2 ml to 1 ml, so 0.5 to 1. Again, we're not ever going to give more than 2 mLs in one syringe in one injection site at the same time. Okay, we're always checking our medication 3 times, right? We're always doing our 3 checks of our 7 rates. Okay, so insulin. We're going to talk about insulin because a lot of your patients will be taking insulin. Now, in the state of California, it is not within the scope of practice for medical assistants to administer insulin. But there are other states that I believe it is. So that's why that's another reason why we're gonna talk about it, because you're, when you're done with this program and you get certified nationally, you could go move to any state and go work wherever, right? So we want to make sure that you're well prepared and you know everything you need to know. Okay, but just remember that when you're going to your externship site and when you're working in California, you're never going to be giving insulin. Okay, insulin and heparin are both very high risk drugs. Okay, there's a high risk of causing great harm to your patient if given incorrectly or if the dosage is given incorrectly. So it's really out of our scope of practice. Okay, but insulin is always measured in units, should always be stored in the refrigerator. You always want to use a special insulin syringe. Okay. Usually when we're giving insulin in the hospital, okay, as a nurse, we're giving two different types and typically mixing them. One is a short acting and one is a long acting, just for your information. The abdomen is usually the most common site and easiest to get to, and where even, like I said, the skinniest of patients have adipose tissue, and it's absorbed more quickly there. And you're never going to rub or massage the site after the injection, especially with heparin. Okay, so again, abdomen's the preferred site. You never want to give it closer than 2 inches to the umbilicus, the belly button. And with these, you always want to rotate the site, so you never want to give it in the same site, every day. You want to inject this drug slowly and leave the needle in place for 10 seconds after injecting and then withdraw it. And you never want to rub or massage the site after a heparin or insulin injection. Okay, so let's talk about vaccines, how much we need them. Okay, so there's some diseases that are still common in the US, such as varicella, pertussis, hepatitis B, and influenza, pneumococcus. Okay, and it's kind of cyclical, right? When there are lower immunization rates for these diseases, the cases go up, right? Less people are immunized, so more people get them. And you can see it on graphs. And the two are directly correlated. Okay, specifically measles and mumps and Hib. We've seen those increase over the past 10 years or so. International travel, right? You always want to make sure that you've got immunizations for polio, rubella, diphtheria, measles, mumps, because just a plane ride away, you can go to a country where these diseases are running rampant, right? They're very prevalent. And then tetanus, we will never be able to eradicate, right? It's always there out in the environment, unfortunately. But we can protect ourselves really easily by getting a tetanus vaccine. Okay, here's a long list of diseases that are preventable by getting a vaccine. It's pretty cool, right? You don't have to memorize this list, okay? But just be aware, right, that there's a lot of them, a lot of diseases that we can prevent with immunization. Some of them are kind of awful, right? Like whooping cough, that's horrible to see. Tetanus in a baby, scary. This is a really extreme case of varicella or chickenpox that looks horribly painful. Polio, that's another one, really awful, debilitating, crippling, right? Measles, influenza, yeah, we all get it, right? So the best thing you can do to protect your health and your patients is cover your bases and get all your immunizations, right? So our most common ones are Tdap, influenza, hepatitis A, hepatitis B, varicella, MMR, that's the measles, mumps, rubella, it's a combo vaccine. So is the Tdap actually. Tdap is tetanus, diphtheria, and pertussis. Okay, pertussis is whooping cough. That's another one that we had a outbreak of in Santa Cruz, I remember maybe about 5 years ago. That's a horrible one for little kids to get. And then, of course, COVID-19, which we've all heard a lot about lately. Okay, so let's talk about vaccine safety. So vaccines are held to the highest standard of safety for pretty much for anything that the CDC reviews and the FDIC. The US has the safest and most effective vaccine supply in history. So that means based on the vaccines that we have and the vaccine injury rates, ours are the lowest. Vaccines have to undergo typically years of testing before it can be licensed, right? So even the COVID-19 vaccine is not technically licensed yet, right? It's approved under emergency use, but it takes years and years of testing before it can be licensed. And then once that happens, they're continually monitored for their safety and effectiveness. Okay, so it's not just a one-time thing. But just like any medication, any drug, any procedure, anything that we do to our patients, they can cause side effects. Okay, so that's why we always give our patients the VIS, the Vaccine Information Statement, so that they're well informed about the typical, and possible side effects. Usually they're pretty mild, but you want to make sure your patients are informed. Okay, for each and every single vaccine that they're getting. That way they can review the risks and the benefits, right? So the main thing with anything we do in medicine is that the benefit has to be greater than the risk. Okay, so if we're talking about a very risky procedure and it has a very low possible benefit to the patient, typically, a physician is not going to move forward with that. So they have to weigh that cost first for them because they don't want to harm their patients, right? And then the patients really need to weigh that as well, even if they're given the option of doing something that has a low benefit but high risk. Okay, and so bottom line, vaccines and immunizations have a very high benefit and a relatively low risk. Okay, so that's the most important thing to remember with everything in medicine, but particularly vaccines because they are kind of a controversial topic. Okay, I'll get off my soapbox. So when we're documenting our administration of a vaccine, here's an example, right? You always want to put down that you gave the patient the VIS and the date on it. Okay, that always has to be documented. And typically you're going to have the patient or the parent sign a consent form prior to giving the vaccine, right? Okay, so there's different types of vaccines, and each one is designed to basically teach your immune system how to fight off those germs and diseases that it's designed for. Okay, so when they're created, the factors that are considered is how your immune system is going to respond to the germ and who needs to be vaccinated against it, and then what's the best technology or approach for delivering the vaccine. And then the type relies on these factors. Okay, so there's now 6 main types of vaccines. There are live attenuated, inactivated, toxoid, subunit, which are recombinant, polysaccharide, and conjugate vaccines, mRNA vaccines, and then viral vector vaccines. So we'll just touch on each of these a little bit. So the live attenuated vaccines use live viruses or bacteria, but they have been weakened. Okay, so they're kind of diluted, and that's what attenuated means. It means that they've been weakened. So they're live, but weak. Okay, and this is done by repeatedly culturing the bacteria or virus. So it's rendering them unable to actually cause the disease, but it can still stimulate your immune response that can protect against future infection. Okay, so protection from a live attenuated vaccine lasts longer than those by a killed or inactivated vaccine. So they're more effective. Okay, so examples of these are the MMR, measles, mumps, rubella, varicella, the nasal influenza, the zoster, which is shingles, and then rotavirus. So inactivated vaccines do not contain any live viruses or bacteria. They are killed using a chemical treatment or high heat. So they are unable to replicate and they can no longer produce the disease in the body, but they still stimulate our body's antibody production, which create immunity to the disease. And these ones always require multiple doses because they're not live, right? So it takes a couple opportunities of introducing this killed virus or bacteria into your body in order for it to create the antibody production. So examples are the inactivated polio, which is IPV, hepatitis A, and the rabies vaccine. Okay, toxoid vaccines. These are for the bacterias that the diseases that are not actually caused by the bacteria itself, but by a toxin like a byproduct that's produced by the bacteria. Okay, so these immunizations are created using the inactivated toxins from the bacteria. So these are considered inactivated vaccines. They're very similar to the last ones that we talked about. But they're given their own category because they contain the inactivated toxin, not actually the bacteria itself. So examples of this are diphtheria and tetanus. Okay, and those are usually part of a combination immunization with pertussis, right? So you can have diphtheria, tetanus, pertussis all together. The DTaP or the Tdap. And then the tuberculosis or BCG vaccine is a toxoid vaccine. Subunit, recombinant, polysaccharide, and conjugate vaccines. These all vary in the manufacturing. The subunit, polysaccharide, and conjugate vaccines contain only pieces of the pathogen that they're protecting against. Recombinant vaccines are produced through recombinant DNA technology. And these different types of vaccines allow the options to vaccinate almost everyone, including young, elderly, people with weakened immune systems, and long-term health problems. The limitation of these vaccines is that you need a booster shot to get ongoing protection against the diseases, so to re-stimulate antibody production. So we'll compare the conjugate versus polysaccharide. So in the polysaccharide, only the sugar part of the bacteria is used, so the capsule of the bacteria. The conjugate vaccines are polysaccharides that are attached to a more complex protein. The conjugate vaccines can stimulate cells in the immune system that polysaccharides cannot, okay, because they're more complex. And the conjugate vaccines are more potent and they're considered to provide superior long-term protection. And the decision on which to use is based on the patient's age, their medical conditions, and other factors. So you have the PCV13, which is the pneumococcal conjugate vaccine, or you could get the PPSV23, which is the pneumococcal polysaccharide vaccine. So both of these vaccines are offering protection against pneumococcus, but in different delivery systems. Okay, hopefully that makes sense. There are other examples of these are the influenza, the meningococcal, we talked about the pneumococcal, pertussis, that's whooping cough, which is usually combined with in the DTaP or Tdap, HPV, human papillomavirus, hepatitis B, shingles, and Hib, which is Haemophilus influenza type B. Okay, so the messenger RNA vaccines, mRNA, these are the hot topic right now, right? So this technology has actually been in development for decades. I think 1970 was the first time it was used. So it has a very short manufacturing time and very low manufacturing costs, right? So it doesn't cost very much to make, and they can make it very quickly, which is why this delivery system was chosen for developing the COVID-19 vaccine. The only problem with them is that they're very fragile and they have to be kept at low temperatures, and they go bad pretty quick when outside of those low temps. Okay, so they work by triggering an immune response from proteins that they chemically combine. And so they induce immunity both cellular, on the cellular level, and with B cell antibody production. So COVID-19 is the first mRNA vaccine that's been approved. They have used mRNA delivery systems in other areas, such as chemotherapy type of drugs, but this is the first vaccine, right, using this technology. And contrary to popular belief, mRNA vaccines do not alter a person's DNA, right? They're just messengers. So they just tell the cells how to respond. All right, so viral vector vaccines. These actually modify another virus and then use that to transmit and deliver protection from the intended virus. So these ones that are used as vectors are the adenovirus, the influenza, the measles virus, and vesicular stomatitis virus, VSV. So the most recent use of this was for the Ebola virus and then COVID-19. And studies are still being used for Zika, flu, and HIV ongoing for the viral vector. Common vaccines given subcutaneously. MMR. Remember, do not ever administer the MMR to a pregnant patient, and they should avoid pregnancy for 3 months after receiving the vaccine. Varicella. MMRV, which is the measles, mumps, rubella, and varicella all together. Nice big combo. Zoster, inactivated polio. This can actually be given sub-Q or IM. Pneumococcal polysaccharide also can be given sub-Q or IM to anyone over the age of 2. And that's the Pneumovax 23. So these are like the brand names for these, a lot of these vaccines. Varivax is a varicella, Proquad is this 4 combo, Zostavax is for the zoster, Ipol is for the inactivated polio, and the Pneumovax 23 is the pneumococcal polysaccharide. Okay, so let's talk about the injection sites for subcutaneous. Okay, so the most common one for immunizations is the fatty tissue that's over the triceps muscles on the back of the arm. You can also use the fatty tissue over the anterior lateral thigh muscle. Okay, right here. You can use the abdomen. Just make sure that you're avoiding 1 to 2 inches from the navel. So find the umbilicus and then make sure you measure out like a 2-inch, circle radius around it and don't administer there. Upper back. I've never given one in upper back. I'm probably supposed to say lower back, the flank area, right? That's a good spot, actually. What do they call it? The muffin top. Okay, but for vaccines, these are our recommended injection sites, right? For babies up to 12 months, on the thigh, and then for anyone 12 months and older, usually they go on the tricep. For insulin and heparin, typically it's the abdomen. For pregnant patients, that then usually move around back to the flank, right? Easily accessible fatty areas. And the insulin is actually absorbed faster when it's injected into the abdomen. Okay, for anything that a patient's getting regularly, you want to make sure you're rotating the injection sites to keep the skin healthy, and make sure that each injection site is at least 1 inch from each other. Failing to rotate sites can cause scarring and then hardening of the fatty tissue, which is uncomfortable. Okay, so important considerations. We always want to ask our patient about any allergies to medications before we administer anything, right? Make sure for sub-Q that the drug is non-irritating, and ensure that it's less than 2 mLs. And all refrigerated medications must be kept within a controlled temperature range. So there'll be a special refrigerator, and it has to be checked twice a day. If you're ever become a lead MA, that's probably going to be one of your job duties, is to check the temp and log it and make sure that it's staying within its parameters. All right, you want to make sure you separate your injections by at least 1 inch if you have to give multiples. Rotate the injection site if it's something that the patient's getting regularly. Never inject into any hardened areas, inflamed, reddened, burned, edematous, because these will not absorb properly. Okay, so anytime you're giving any injections, make sure that your site is stable. Okay, this is my little acronym here. STABLE. Okay, so look for scars, tattoos, arteries, bruises, lesions, and erythema, which is what? Basically just redness. Okay, so if it's stable, then don't inject there, right? Never massage after administering insulin or heparin. And if the patient bruises easily, apply ice to the site for 5 minutes after injecting. So especially with patients who might be on anticoagulants. Okay. Go get help if after administering the injection that the site continues to bleed. You can't control the bleeding. If the patient's having a lot of pain, right? There's discomfort, but they should not be in pain. Okay, if you accidentally inject the medicine into the wrong area, all right. If a rash develops around the injection site, if the patient develops a fever, and any sign of an allergic reaction, right? Hives, any signs of anaphylaxis, scratchy, itchy throat, swelling lips, difficulty breathing, anything like that. Go get help. So a patient can have an allergic reaction, right? Obviously, after being administered a drug. Usually it's mild, but worst case scenario, anaphylaxis, right? A severe allergic reaction that occurs suddenly and immediately. So that's the thing that people forget about anaphylaxis, is it comes on right away, right? So the patient will still be in the office, thank goodness. The only time usually that people experience anaphylaxis out, about doing their daily duties is if they are allergic to, say a bee sting and they get stung by a bee, if they're allergic to peanuts and they actually ingest a peanut, something like that. So it comes on very quickly and suddenly. It is a very serious condition that requires immediate medical treatment. Okay, signs and symptoms of anaphylaxis. So you always want to screen your patients after administering any medication to them. Okay, so pruritus or itching, urticaria, which is hives, dyspnea, difficulty breathing, dysphagia, difficulty swallowing, signs of shock. Okay, so that would be like uncontrollable shaking, right? If their pulses get weak and thready, convulsions, right? And loss of consciousness. Okay, these are all very serious signs and symptoms. Yeah, death can occur if these are not treated quickly. Okay, so after we give an injection, this is per site policy, but typically you're going to have the patient wait in the office 10 to 15 minutes after receiving an injection to screen for anaphylactic symptoms. Okay, you want to especially be alert for those symptoms after administering allergy injections or penicillin. So those are kind of more commonly known to cause anaphylaxis. You should have an EpiPen available at all times in your medical office, and you should know how to use it. Okay, they're pretty easy. Pull it out of the box, pull the cap off, and just push it into the patient's, usually the leg muscle, right? So this is an IM injection. So it's automatic, and it contains a pre-measured dose of epinephrine, which is great. So you don't have to worry about measuring it out. Okay, so you want to get that patient the EpiPen immediately after an anaphylactic reaction occurs. Once the patient's stabilized, then the provider will probably order an injection of antihistamine. And you always want to make sure that there's emergency crash carts on site in your clinic and that they have non-expired supplies such as EpiPens. Okay, so that's the medical assistant's role there in treating anaphylaxis. And I believe that is the end of our lecture. Yep, we'll see you next time.